So, again, thanks a lot to Focus Point for inviting me to give important talk on two topics. So I'll be splitting my talk into two different sections. The first one is called the silent thief of sight.
哦，Doctor 可以拿靠近一点点那个麦
Oh, I'm not used to this as well. Okay.
Is it better?
So
okay.
a bit of a background. I did most of my training in UK and got my qualifications from UK as well.
Okay.
So the first talk is called the silent thief of sight. Anyone hazard a guess? What's the silent thief of sight?
Silent thief of sight. Silent is something quietly.
Yes, like
thief
creeps.
is something steal from you.
Correct.
So something is which is quietly steal
Insidious
something.
and suddenly steals from you your sight,
Okay.
and it is glaucoma. So this is 青光眼.
青光眼.
First
Okay.
Chinese word I can say now. Okay.
啊
So a lot of us, you may or may not know, will be walking around amongst us with tunnel vision.
Okay.
Literally, there are people who are suffering, not knowing that they are slowly losing their peripheral eyesight.
Oh.
Centrally, they can still manage, and it's at night they notice that they are struggling even more. So, driving, they don't notice anyone driving coming from the side.
What they can't see.
Yes.
Can't really see.
Yes.
All right.
So it becomes a bit of a worry for them, a bit of anxiety when they are having driving trips or even having night trips. Okay. So what is glaucoma? So glaucoma is a chronic progressive optic nerve disease where there's a combination of optic nerve damage as well as visual field damage. So
Okay.
this is the very key thing. A doctor will only diagnose glaucoma when there is nerve damage and visual field damage. Okay? So as you see the visual fields, there's a dark patch at the top.
This one.
Yes.
Okay.
As glaucoma progresses uncontrolled, it becomes more and more constricted. So hence the tunnel vision.
Oh. Okay.
So the most common glaucoma term that we use is called high tension glaucoma, and these are optic nerve damage as well as visual field damage in patients with pressures in the eye over 22 millimeters mercury. This term can sometimes be mixed with another condition called ocular hypertension,
Okay.
where there's no optic nerve damage and no visual field damage, but
Okay.
there's high pressure. So a lot of times I get seeing patients for second opinion. They come to me and just say, "Oh, I've just been told by the doctor I've got glaucoma. Am I going to go blind?" Then I go through the test, and I find out that they were just warned that they were having the risks of glaucoma rather than glaucoma. So these are terminologies that sometimes is misrepresented to patients.
Okay.
Okay. Another type of glaucoma that patients tend to find it difficult to understand is the normal tension glaucoma, which means even though the pressure is below 22, within the normal range, but there's damage to the optic nerve and there's damage to the visual fields, then they are on the trend of losing sight despite normal pressures.
Which means it's like normal vision, maybe we won't realize certain problem.
Correct.
But this thing is getting
Worse
tougher
and
and tougher.
worse.
It's like
Correct,
suddenly
yeah.
one day, how come my eyesight a bit
Correct.
tightened than the narrow
Yes.
view I ever
so
have?
most patients that come to
Alright.
me have already been pre-diagnosed by someone else, or they come with sudden onset visual field defect. They say, how come I can't see at night that well, or I'm feeling a bit more dangerous when I'm driving?
It's already occurring idea.
Correct.
Okay.
And these symptoms only occur when it's 75% nerve damage has already presented. So it's already
Okay.
quite late on. Okay? And then the final one that I normally see quite a lot is glaucoma suspect, where they have a bit of changes to the optic nerve and maybe some changes to the visual fields, but it's not consistent with glaucoma. So these are the patients that we always tell them to be more careful. We have to monitor them regularly, once a year at least.
Okay.
And the risk factors for this would be high pressures, 22, 23, strong family history of glaucoma. So glaucoma is a genetic predisposition. So if you do have a family history of glaucoma, my advice is after the age of 40, get yourself checked once a year at least. Come to your friendly optometrist in Focus Point or come to one of the eye doctors just for a screening. Trauma is also another cause of secondary glaucoma. So this is when there's direct damage to the eye.
Okay.
So for many people, sight is one of their most precious senses. And I would say the same as well. And the impact of glaucoma extends beyond the loss of vision. And there are three types of impact that we talk about. First is physical impact.
Physical impact.
30% of patients with glaucoma claim that they fear tripping and falling when moving around because they lose their peripheral sight. There's also the practical impact where they have difficulties doing day-to-day activities. So 45% of these patients complain of that. And finally, emotional impact. About 40% would be worrying about their future because they don't know whether they need extra care and also the impact they have on their own relatives or their friends because they need extra help from them. So the life of glaucoma patients can be affected many ways. Number one in two find difficulties reading. They just notice that in dim lighting, they can't see as well. They may say that smaller print is not as clear as it used to be. And then you have patients who have difficulties finding employment. 1 in 3, they find that it affects the ability to work as they would normally do. 1 in 3 will also fear of tripping down and falling, as we said earlier. And 1 in 4 may have psychological impact where they lose confidence in going out. Okay. So what is the aim of glaucoma? We know that by reducing the eye pressure, we can reduce the risk of the development of glaucoma damage when there's elevation. Okay. So in patients who are ocular hypertensive, where there's high pressure, we know that every millimeter mercury of reduction in the span of 5 years, we can reduce the risk of progression to glaucoma by 10%. So it's quite important to know that if you have high pressures, at what level it is and whether it needs to be treated earlier or not. So the optometrists know how to do this as well, but most times you would need to rely onto a eye doctor to discuss the impact of this. We also know that by reducing the eye pressures, we can reduce the progression of glaucoma in pre-existing glaucoma. So let's say a glaucoma patient is on treatment, they've got eye pressures of about 19, 20, which is still normal range, but they're slowly still going blind. Then we know that it's important to lower the eye pressures even more, especially down to the low teens. So the principles of glaucoma management is to, number 1, reduce the risk of glaucoma progression. Number 2, to maintain useful vision for the rest of their lives. Number 3 is an arbitrary number. Normally for me, I try to reduce pressures down to at less than 14 millimeters mercury if possible. But if I find that a patient has been quite stable at slightly higher level eye pressures, we leave them. Okay? And then we can adjust the eye pressure target depending on whether there's further progression or not. So the ideal eye pressure is when the glaucoma does not progress. That's the key thing. Okay? Different patient has different levels. Some may need low levels. Some may have high levels but still no progression. We also have to discuss with patients about non-pressure dependent factors, and this include sleep apnea. So if you have partners who snore a lot at night, this is an indication of potential sleep apnea and higher risk of glaucoma.
Higher risk of glaucoma.
Yes. And then there are also some patients who are known to be hypertensive, but they may be over-treated. When the nighttime, the blood pressure drops down to a very low level to the point that blood flow to the brain has been compromised. So that is
Has
something
been
that
compressed. Okay.
yes, because it's not enough to go to the brain or to the eye.
Oh, so
Okay.
that's why it cannot function. Jam
Not
already.
as well, yes.
A bit
It's not as
jam
good as
already.
good. Yeah.
Okay.
And finally, there's
Oh.
been a strong link between glaucoma and neurodegenerative diseases. So the classic example would be Alzheimer's or dementia. Okay, there's a link there.
Understand.
So, what type of medications we can use? So
Okay.
the aim of using medications is to reduce aqueous production. So it's like the factory in the eye. So it's a little body here called the ciliary body.
Okay.
Or to increase the drainage. So the drainage is called the trabecular meshwork or the uveal scleral pathway. So two mechanisms. One is to reduce production and one is to increase the outflow.
Okay.
Okay? So this is just a schematic of where the medications work in the eye.
Okay.
Okay? So we are quite fortunate in this lifetime because there are actually 7 main classes of eye pressure lowering medication. So that's quite a lot. Okay? Mostly are used as eye drops.
Okay.
All can reduce eye pressures by at least 15 to 35% of baseline. That means if you were never using drops before, first time seeing a doctor, your pressure is that level, it can reduce it by 15 to 35%.
Wow.
Okay?
Okay.
Medications, the eye drops from different classes can be combined. So type A can be with type B or type A and type C. So I'll show you all the drops afterwards, okay?
Okay.
However, when you combine them, it doesn't mean that if type A is 20%, type B is 20%, I get 40%. It doesn't work that way. It's just a little summation and a gradual reduction. Okay? So these are the 7 main classes available on the market now. So we are actually quite fortunate because you can still maintain good pressure control with eye drops for a long period of time before requiring lasers or surgery.
Okay.
So patients always come to me and worry about eye drops. And I understand why. Because if you look at this, there's so many types of eye drops available. Okay?
It's like a daily usage, right?
Yes. So these 2 last pictures are the latest ones available and they're doing a good job as extra armamentarium to help fight against glaucoma.
Oh, wow. Okay. These
So-
two.
Yeah, the last 2. This is extra help too.
Extra help.
Yeah, okay. So, what if the drops fail? What's next? So, we can do procedures to control the eye pressures.
Okay.
One of these procedures is called a laser trabeculoplasty, where a laser beam is shot to the trabecular meshwork, so the drain in the eye, where we increase the drainage. So it's like puncturing little holes on the drain itself. And the types that we have are argon laser trabeculoplasty,
Okay.
selective laser trabeculoplasty,
Selective.
or micropulse laser trabeculoplasties.
Micropulse. Okay.
Basically, all these lasers do similar effects on the eyeball at the drain. Okay. Another type of laser that's available is usually used by doctors to prevent acute angle closure glaucoma, which means that they can come suddenly, the pressure shoots up.
Oh,
And
okay.
the reason is the little area here is blocked up. So the fluid is not able to flow very nicely.
Okay.
So we do a laser called laser peripheral iridotomy where we puncture a hole onto the iris, the color of the eye,
Okay.
and it acts like a bypass. So instead of the
Like a
flow-
U-turn like that.
Yes, yes. So
Okay.
it's just to bypass the blockage so that it can open up the drainage again.
Oh.
Okay?
Okay.
So these are the angle closure glaucomas.
One of the ways.
Yes. Other procedures that may be used will be more severe glaucoma where we use filtering surgeries.
Filtering.
And- yeah, filtering. So basically it's like puncturing a hole or putting a pipe in the eye.
Okay.
Okay? So the gold standard operation is called a trabeculectomy. This has been around for the last 40 years.
Okay.
And it's called a guarded filtering procedure that removes part of the trabecular meshwork, the drain.
This one.
Yes. So it removes part of the drain and opens up a hole And this is a flap. It's called a scleral flap. So it's like a little guarded drain. Okay? And this is enhanced with either chemicals called 5-FU or mitomycin C.
Okay.
These chemicals are used to reduce the healing process. Because can you imagine that after surgery, there's a lot of inflammation in the eye, and this area that was open can be closed again because of scarring.
Wow.
Okay? Finally, a more advanced procedure is for patients who have very severe close angle glaucoma, which means the drainage doesn't work at all. 360 degrees of drainage doesn't work, then we have to put a tube inside. So this tube shunt surgery or drainage implant surgery would involve the insertion of a tube or glaucoma valve to increase the aqueous flow, the water from within the eye to the outside of the eye. There are two main types that are being used nowadays. There's the valved implant, where there's a little flap which opens when the pressure goes up and closes when the pressure goes down, and that's called the Ahmad glaucoma valve. And there's the non-valve implant, which is called the Barveld tube. This takes a bit more longer to manage after the surgery, but it is done quite a lot by a lot of us glaucoma surgeons. Normally, when the eye is blind or painful, this is the fourth type of procedure that we do, which is called a photocoagulation using a cyclodiode laser. What it does is actually sending lasers to the factory and damaging the factory so that it doesn't produce the fluid anymore. So with time, the pressure will just reduce to a equilibrium where no more aqueous will be produced and the pressure should maintain as it is. Okay, but these are normally for blind, non-seeing eye, which have become painful with the eye pressure being high. So currently we live in a world of a lot of progress, and the interesting procedures that we have available include little stents being put in the eye. And these are called intraocular stents. So the one that is being used a lot by anterior segment surgeons, where the cataract surgeons do this at the same time, would be called the eye stent. And this is inserted in the drainage site. It's like a little plug. Okay, but the plug has little holes where the fluid can go in. And if you can see with the penny, that's the 1 penny from America. That's the size of the implant. It's actually very small.
Very small.
Very, very small. Okay. One that I normally use quite a lot is called the PressaFlow micro stent. And what it is also based on your finger. You look at that, it's very, very small as well. Okay, it's less than a millimeter in length. And then what we'll do is we'll implant it through the trabecular meshwork onto the little space underneath the skin.
So it's like a pipe lah.
It's a little pipe.
It's a little pipe.
Yeah.
Okay.
And the latest available in the market is called a
Hydrus micro stent.
Yes. So again, a lot of these procedures are based on the meshwork, the trabecular meshwork, where we insert this little steel shaft into the canal, and we are just opening up the canal so that fluid can flow more efficiently.
So this is made of steel.
Yeah, it's made of, it's not steel, it's like titanium or...
Titanium.
Yeah. So it's expensive.
Titanium.
Yes.
Okay. Okay.
So basically, this is a quick run through of glaucoma, and it's a very important disease that a lot of patients need to know. Okay. So I'll move on to my next talk. Okay. The next talk is called the window to the soul. Quick question.
All right.
What is the window to the soul? Does anyone
Window
know?
to the soul.
Yes.
It's like focus point always mentioned. A good vision worth a lifetime.
What's a window to the soul?
Yes.
So, the cornea, or again, my Chinese coming out, 眼角膜. Okay?
眼角膜, 眼角膜.
Yes. Basically, this is a clear dome. Okay, it's actually a transparent dome-shaped window covering the front of the eye. A lot of patients that come to me, then they say, "Oh, why 耳尖无数?" But in actual fact, it's the 眼角膜无数 because it's actually the surface that's covering
Surface
the
goes wrong already.
Yeah, the 瞳孔 is that right?
瞳孔.
Okay, see?
Okay.
Mandarin very bad.
It's okay, it's okay.
So as I said, it's normally clear.
Hmm.
It has a very shiny surface due to the lack of blood vessels.
Oh.
However,
Hmm.
I'm very sure a lot of my optometry colleagues here have had encounters with patients.
Hmm.
It's extremely sensitive
Hmm.
because it has the highest concentration of nerve endings compared to other parts of the body. So a tiny fiber in the eye, tiny foreign body, a little poke in the eye can cause a lot of pain. Okay? Optoms has faced this before, so we use drops to numb the eye before we examine them.
Okay.
It's very, very thin. It's only 0.5 millimeters in thickness, and it comprises primarily of 5 levels.
5 layer.
Yes.
Alright,
So from the front of the eye to the back of the eye. Okay. So there's the epithelium, which is regenerative. So this is where if you accidentally get a cut in your cornea, that is the part that normally gets damaged and it reheals. Okay.
Epithelium. Okay.
Epithelium. Bowman's layer is just a
Bowman.
little membrane. It's a basement membrane for the
Okay.
epithelium. Stroma is the majority thickness of the cornea. And then the decimus membrane and endothelium is the inner lining of the cornea. Okay. So, what conditions can cause damage to the cornea? The main one that we worry about all the time would be keratitis or ulcers. And these are infections due to bacteria, viruses, or fungi which enter the cornea.
I always thought ulcer is only at the lips. Eyes also got ulcer.
Not that, it's just the different types of damage to
Okay.
the eye. Although it's very uncommon,
Okay.
this type of infection can also arise from corneal injury, micro injuries when wearing contact lenses.
Oh, sengit a bit. You know, sometimes
when
to
you
overpress.
Correct. When you put it in or when you remove the pinch effect, sometimes you can accidentally scratch your cornea without realizing.
Wow.
So that's why you can have this discomfort.
Okay.
So this is the cornea which has a ulcer on the eye.
Okay.
And this is another infection. This was bacterial. This is viral.
Okay.
So this is what we call herpetic keratitis. It's the herpes virus. And
Herpes virus.
Yes, but the herpes virus in the eye is not the same as the herpes virus due to sexually transmitted diseases. So it's two different types.
Oh.
Okay?
Okay.
So I always tell my patients that so that they don't get too worried. Okay?
No.
And the last one is the worst one is the fungus.
Fungus.
Okay?
These are.
So
Okay.
if left untreated, it can get bad.
It get
How,
worse.
yes. How bad can it be? You can get the ulcer becoming bigger,
Ulcer bigger.
and you can get hypopyon or nana. It's the same as nana inside the eye.
Oh,
So it's
wow.
pus.
This one looks scary though.
Yes, it's very bad.
Oh.
And normally, a lot of times, patients are sent to me by other doctors when they come to that position. So it's become too difficult for one of the doctors to take care. Then they ask me to take over to help them recover.
Okay, I have got one question. Usually when happen for
Hypopyon, yeah.
hypopyon, right? How was the surface will look like? The whole eyeball will like a bit.
It'll be very tense, you
It'll
feel
very
that it's
bengkak,
red. Yeah,
okay.
you feel very swollen, very red. Okay, vision will be very bad, and the patients will be in pain.
Oh, which means it goes to that stage already. Wow.
Worst case scenario, you can get the whole cornea. You see, the clear part has all become white already.
Straight away, like one thing
Correct.
blockage of the eye already.
Correct, and these patients normally are unlikely to recover their eyesight, unfortunately. And then I'll have to discuss with them about later on having to do a corneal transplant. So 眼角膜, we have to change the whole thing.
Wow, take out the whole thing, then
Yes.
replace a new one.
Correct.
Wow.
Okay. So, stepping on after infections, we talk about degeneration. So these are changes because of aging.
Okay.
The one patients that I normally see are called keratoconus or keratoectasia with thinning. So misshaping of the cornea with thinning. This is a progressive disease where the cornea thins and it changes the shape. So 散光 becomes worse. They just say, oh, how come my 散光 is getting worse and worse?
It's like the light is like cannot focus,
It
right?
becomes more glary, yes. Sometimes these patients can present at adolescence, so after teenage years, and what it does is it changes the shape of the cornea.
Okay.
Then patients will notice, oh, I can't see far that much anywhere. I have to keep putting on more and more short-sighted spectacles. So 近视 becomes worse and worse. Okay? And when it's bad enough, it can lead to swelling and also scarring. So you can see there's the swelling and then you can get scarring. Okay? Besides degeneration, you have dystrophies. Dystrophies are genetic changes where patients have family histories of this problem.
Okay.
And there are more than 20 types of this.
Wow.
One of them would be basement membrane dystrophy. This one is called lattice dystrophy. So it looks like little ropes on the surface of the cornea. And then there's granular dystrophy. It's like little granules on the surface of the cornea. And this is another type as well, Meesmann dystrophy. Okay? So all these kinds of dystrophies will eventually lead to partial sightedness or blindness, and they will require corneal transplant. Okay? In patients with dystrophies, they normally have epithelial erosion. So remember the outer layer that we talked about? It can break down, and patients can complain of pain, especially when waking up in the morning.
Okay.
And vision can be degenerative as scarring occurs. Treatment for this would be loads of lubrication to prevent the eyelids scratching on the surface.
Okay.
A special contact lens called bandage soft contact lens, and this is just a protective layer for the cornea to heal.
Okay.
We can also do laser on the surface to remove the abnormal epithelium,
Okay.
or eventually they go for corneal transplant.
Okay.
So next step is surgery for patients with cornea diseases.
Okay.
First, you have the old style, full thickness penetrating keratoplasty, where the whole cornea is taken out like an apple core. We'll get a donor's eye and put it back on and replacing it.
Oh.
Okay? So these types of patients are normally those with full thickness scarring. That means the cornea is really badly scarred from infections, trauma, or very bad keratoconus. Okay? The next type of corneal transplant that I do is called deep anterior lamellar keratoplasty, which is just a partial thickness corneal transplant. We remove the abnormal part of the front part of the eye and we leave the normal inner part. After the surgery, it looks similar to the full thickness corneal transplant.
So just now you mentioned the 5 layer lah.
Correct.
Remove the
So-
few parts of
Correct.
outside.
So the first four-fifth
Oh, 4 to 5. Oh.
of the layers
Oh.
and then leave one single layer back.
Oh.
Okay? And this is normally done for conditions called keratoconus. Okay? And then there's also another surgery called decimate stripping endothelial keratoplasty, which is a reverse of the deep anterior lamellar keratoplasty, which is down the inner layer I'm changing now.
Oh.
So this one is a condition where Fuchs endothelial dystrophy causes swelling to the inner layer. So I pull off the inner layer and take a thin piece of cornea and re-implant it so that we can get back the clarity again. So
Wow.
if you can compare the picture, this is what the DSAC is, an inner layer, and this is the full thickness corneal transplant.
Okay.
Okay? The current most interesting procedure is called the DMAC. It's just a single 0.01 millimeter thick skin from within the eye, and they transplant it in. This is quite an advanced procedure, which unfortunately I did not have the chance to learn when I was in the UK because it was just very new then, and it's now being used quite a lot in the West. Okay, the procedure is quicker and the recovery is faster.
Oh.
But reports have shown that the results comparing this with the other type, the DSAC, similar.
Oh,
So
it's still similar.
I still continue to offer my DSAC to patients. Okay. And again, we live in a very advanced world now. You have stem cell therapy, which is taking a major role in research and development. So now we can get parts of the stem cells from the mouth or from other parts of the eye,
Okay.
and we replant it onto the affected eye.
Wow.
And another type is they're injecting the cells into the eye to treat the inner lining problems as well. So it's very
take
exciting.
this part DNA, place that DNA inside.
Yes,
Oh.
but this is still research. It's still not
Oh, it's still
fully
research yet.
available yet.
Okay.
Okay. If this does well, then it'll make me obsolete because they don't need a corneal surgeon anymore. Okay.
They definitely still need you.
Well, I don't know. Okay?
You're still one of the great expert. All right.
Yeah. So basically, it was a quick run through
Okay.
of the two main diseases that I deal with. As what Dr. Neo said, we are from Isaac Penang, based on Jalan Larut. For those who are from Penang, they would know that it's the former Mesinaga building next to the previous KFC building. Okay. So thank you a lot for your invitation and your attention.
All right. Once again, greatest thanks to Dr. Adrian. So any Q&A regarding this part? And of course, if any of the friends would like to know more about the details, they can actually check with Dr. Adrian later on. All right, you guys can check out with inquiries, or maybe if any of the issue that they want to check with you. All right, once again, greatest thanks to Dr. Adrian. Right.